Hi guys, today's lecture is all about the thyroid malignancy. Thyroid gland. It is a single bilobed gland in the lower anterior neck. It is largest of all the endocrine glands. It is brownish red and soft during life with two endocrine functions. It basically produces two hormones like thyroxine and triiodothyronine, T4 and T3 from the follicular cells and are dependent on the iodine and regulate the basal metabolic rate. So the thyroxine and triiodothyronine basically produced from the follicular cells and are dependent on the iodine and it regulates the basal metabolic rate. Whereas the calcitonin, it is produced by the parafollicular cells, which has a role in regulating the blood calcium levels. Then comes to the histology. Here we can see these are the follicular cells, these are the parafollicular cells. So the calcitonin is produced by the parafollicular cells, T3, T4 by the follicular cells. Here in this diagram you can see how the parafollicular cells lie in between these follicular cells, these small cells. These are the blood capillaries. So the follicular cells are columnar in the active phase and cuboidal in the resting phase. It basically secretes the T3 and T4. Follicle contains the colloid in the lumen. So this is the colloid in the lumen. Follicles contains the colloid in the lumen. Now the parafollicular cells, C cells, these are fewer, lie in between these follicles. Now here we can see these are the parafollicular cells which lie in between the follicles. These are fewer, lie in between the follicles and secrete the thyrocalcitonin, which help in regulating the blood calcium levels. The causes and the risk factors. The sex. Females are 3 times more likely to develop the thyroid malignancy than men. Radiation exposure. Radiation therapy to head and neck is the cause. Can be the cause. Exposure to the radioactive iodine during childhood, other radioactive substances increases the risk of particularly the papillary carcinoma. Well, if you talk about the genetics, abnormal RET oncogene may cause the medullary thyroid carcinoma. Multiple endocrine neoplasia 2A and 2B syndromes are also associated. Then the family history of the goiter increases the risk of the papillary carcinoma. Now the tumor staging and the classification of the thyroid malignancies. There are different staging systems like the TNM classification, the AMES. So in the TNM classification, the American Joint Commission on the Cancer, AJCC, and the Union International Contour Lee Cancer, UICC, adopted a tumor node metastasis TNM classification system. In this system, the patient age at presentation influences the clinical staging of the thyroid carcinoma. Whereas the AMES, in this system, the patient age, A for age, M for metastasis, E for extent, and S for the size, were usually to stratify the patients into lower risk and high risk groups. Now the AGES and the MACIS system. In the original AGES system, the age, histologic tumor grading, extent, and the size were used to calculate the prognostic score. Because of the infrequent practice of the tumor grading, a more recent modification of the system eliminated the histological tumor grading and incorporated the metastasis and extent of resection. So the MACIS system accounts for the metastasis, then age, then the completeness of the surgical resection, the extrathyroidal invasion, and the tumor size. Now here we can see the TNM classification of the thyroid cancer. The primary tumor, in which there is the T4, the primary tumor. TX is a primary tumor which cannot be assessed. 0 is no evidence of the primary tumor. T1 is a tumor size less than or equal to 2 cm in the greatest dimension, limited to the thyroid. T1 is a tumor size less than or equal to 1 cm, limited to the thyroid. 1B, tumor size greater than 1 but less than 2 cm or equal to 2 cm in the greatest dimension, limited into the thyroid. When it comes to T2, it is the tumor size greater than 2 cm but less than or equal to 4 cm in the greatest dimensions, limited to the thyroid. Whereas the T3 is a tumor size greater than 4 cm, limited to the thyroid, or gross extrathyroidal extension invading only the strap muscles. Well, 3A and 3B. T3A is a tumor size greater than 4 cm but limited to the thyroid. But 3B is a gross extrathyroidal extension invading only the strap muscles, sternocleidomastoid, sternothyroids, thyroid, omohyoid muscles from a tumor of any size. Now if we talk about T4A and T4B, well, T4A is a tumor of any size extending beyond the thyroid capsule to invade the subcutaneous soft tissue, larynx, trachea, esophagus, or the recurrent laryngeal nerve. Whereas T4B is a tumor invading the prevertebral fascia, or encases the carotid artery or the mediastinal vessels. So 4B is basically the invasion to the prevertebral fascias and the access to the carotid artery and the mediastinal vessels. When the regional lymph node, cervical and the upper mediastinal. So NX is the regional lymph node that cannot be accessed, and 0 is the no regional lymph node metastasis, and 1 is the regional lymph node metastasis. 1A is metastasis to level 6-7 nodes, unilateral or bilateral, and 1B is a metastasis to unilateral, bilateral or contralateral, cervical or the retropharyngeal nodes. Levels 1, 2, 3, 4, 5 of the cervical levels. Yeah. Then the distant metastasis, M0 and N1. M0 is a no distance metastasis and M1 is a distant metastasis. Then the residual tumor, RX cannot be assessed presence of any residual primary tumor. R0 is no residual primary tumor. R1 is a microscopic residual primary tumor, and R2 is a macroscopic residual primary tumor. So this is the TNM classification. Now, well, the classification of the tumor according to Dunhill is the differentiated and undifferentiated. We need to understand that the differentiated accounts for 80% and undifferentiated accounts for 20%. Well, in the differentiated, we have the papillary, follicular, papillofollicular, and the HURTHLE cell carcinoma. And the undifferentiated, there is the anaplastic, medullary, malignant, and the secondaries in the thyroid. Papillary account, in differentiated, the papillary account for approximately 60% and follicular 17%. Rest are by the papillofollicular and the HURTHLE cells. Now this is the algorithm of the thyroid nodule management. Well, first we need to take the complete history and the physical examination need to be done. Then initial workup that the thyroid function test, the FNAC and the ultrasonography. Well, if it is a carcinoma, the surgery has to be done. If it is a follicular neoplasm, then if the TSH is low, the iodine scan is required. If it is cold, then surgery need to be done, which reflect towards the carcinoma. Where is it hot, we need to evaluate further. Well, if the TSH is high or normal, surgery need to be done. If it's a benign nodule and it grows, surgery need to be done. And if it's intermediate, then repeat the FNAC. Now, investigations of the thyroid disease. A patient present to us with an anterior midline neck swelling in the investigations here. Well, the thyroid profile need to be done. Usually the patient of the thyroid malignancy are euthyroid. One need to understand this. In thyroid profile, complete TSH, T3, T4 need to be done. Well, what are the findings in the ultrasonography which suggestive of the malignancy? We will see the microcalcification, irregular border of the nodule, increased blood flow to the thyroid nodule, hypoechogenicity, and the absence of a halo. Now, thyroid isotope scanning can be done. A radionuclide scanning of the iodine-123 or the technetium-99 M-square system may be assessed to functional activity of the thyroid nodule and the thyroid gland. Well, iodine-123 scanning tests transport and basically it tests the transport and organification of the iodine. Technetium-99 scanning tests the iodine transport only. One need to understand this. So nodules that retain less radioactivity than the surrounding thyroid tissue are termed as a cold, non-functioning or hypofunctioning. These cold nodules, these are basically retain a less radioactivity than the surrounding thyroid tissue. So these are said cold, and the cold nodules are thought to have lost the functions of the fully differentiated thyroid tissue and to be an increased risk of containing the carcinoma. So cold, C for carcinoma, C for cold. Well, technetium-99 scanning test only the iodine transport, but can be performed in one day and involves less radiation than iodine-123 scanning. So cold nodules identified with this test are also cold with iodine scanning. So this we can see the thyroid scintigraphy within the technetium-99 per technet scan. Here we can see the anterior, right anterior oblique and the left anterior oblique scanning. Now comes the papillary carcinoma. It is the most common type. It accounts for approximately 75 to 80% of the tumors, and it's a male to female ratio. Female to male ratio is 2:1, and mean age presentation is 30 to 40 years. Papillary carcinoma are the predominant thyroid malignancy in the childhood, more common in person exposed to radiation. So, what is the macroscopic classification? It is a minimal or occult, intrathyroidal or extrathyroidal. Well, minimal or occult, it is a less than 1 centimeter with no invasion through the thyroid capsule. Intrathyroidal, greater than 1 centimeter with no invasion through the thyroid capsule, and the extrathyroidal, locally advanced with invasion through the thyroid capsule. Now comes the pathology. On gross examination, the papillary carcinoma is a firm, white and non-encapsulated. The lesions tends to remain flat on sectioning rather than bulging the way normal thyroid tissues of the benign nodular lesions do. Macroscopic calcification, necrosis or cystic changes may be readily apparent. Microscopic features are the cuboidal cells with the abundant cytoplasm, intranuclear cytoplastic inclusion, orphan Annie cells, fibrovascular stroma with the calcium deposit, the psammoma bodies. These are the MCQs basically asked in the NEET exam. What are the microscopic features of the papillary carcinoma? So it contains the intranuclear cytoplasmic inclusion, the orphan Annie cells, the fibrovascular stroma with the calcium deposit known as the psammoma bodies. So here we can see this is a normal thyroid histopathology slide. Here we can see these are the follicles, the parafollicular cells, the colloid in between the follicles. So this is a normal thyroid. Now here we can see the papillary projections. These arrows show the papillary projections characteristic of a classical papillary carcinoma on the histopathological slide. Now what are these? These are the psammoma bodies, the calcium deposition. It is a form of a dystrophic calcification. The necrotic cells form the focus for surrounding this calcific deposition. Here what we can see? Here we can see the fibrovascular core, the optically clear nucleus, the orphan Annie nucleus here. So what we can see here is a characteristic orphan Annie nucleus. The nuclei have a uniform staining, appears empty inside due to the powdery chromatin. So named because they have a cleared out appearance similar to little orphan Annie. Here we can see these are cleared out feature. Well, this the term was basically coined upon noticing the tumor cells with the empty nuclei, or those showing just a thin rim of peripheral chromatin in sections of the papillary thyroid carcinoma. Well, the appearance of these cells, abnormal nuclei, it was basically differentiated by the Dr. Nancy Warner. So she saw that it resembles an eye of an orphan Annie. Little Orphan Annie was a daily comic strip created by the American cartoonist, which was quite popular at the time of the 1894 and 1968 around. Well, the FNAC biopsy is diagnostic. Treatment, well, ipsilateral lobectomy and hysterectomy if no lymph node metastasis is there. Near total or total thyroidectomy is done with modified radical or the functional neck dissection if there is a positive lymph node metastasis, and prophylactic lymph node dissection is unnecessary otherwise. Well, the variations of the papillary carcinoma are different, like the follicular variants, there are solid variant, encapsulated variant, the diffuse sclerosing variant, the tall cell variant, the columnar cell variant, the oncocytic oxyphilic variant, the macrofollicular, the Kirby-form modular, the papillary microcarcinoma. So let's start with the follicular variant of the papillary carcinoma. It is composed of the follicles throughout, no papillae. Infiltrated type, encapsulated type, Lindsay tumor. The diagnosis rests on the identification of a typical nuclear features of the papillary carcinoma, like the orphan Annie and all that. So the solid variation, more than 50% solid, pacting, and trabecular growth pattern is seen. Well, the encapsulated variant, distant metastasis is 0 and the nodal metastasis is seen. Now the diffuse sclerosing variant. The nodal metastasis nearly always present, lung metastasis are common, multiple brain metastasis may supervene, and the psammoma bodies are typically abundant. What in the tall cell variant? A single layer of tall cells, height greater than 3 times the width, abundant acidophilic cytoplasm, more aggressive than the conventional form. Columnar cell variant, the pseudo-stratified layer of spindle tumor cells. Then comes the oncocytic variant and the macrofollicular variant, large follicles distended into the colloid, mimicking the colloid nodule. The Kirby-form modular variant, the papillary carcinoma measuring 1 centimeter or less in diameter. So what is the histologic differentiation? It is a minimally invasive and the frankly invasive. The minimally invasive invasion into but not through the capsule at 1 or 2 sites, where the frankly invasive evidence of the vascular invasion or invasion through the thyroid capsule. So the follicular cancers. Now comes the follicular. So the female-male ratio is a 3:1, accounts for 15 to 20% of all the thyroid cancers. Mean age of presentation is 50 years, more frequent in the iodine deficient areas. Papillary was more frequent in the due to radiation, but these are more frequent in the iodine deficient areas, and history of the long-standing goiter is there. Well, if we talk about the pathology, it's usually encapsulated and solitary, spread usually by the blood, most commonly to the lung, brain and bones. Lymph node metastasis is seen in 10% cases. Well, if we talk about the gross pathology, minimally invasive follicular carcinoma, solid, fleshy and tan to light brown, show evidence of invasion into but not through the tumor capsule at 1 or more sites. The size range from less than 1 centimeter to over 10 centimeter. Now comes the frankly invasive follicular carcinoma. Shows the invasion through the capsule, and the tumor often exhibit the vascular invasion. Tumor infiltration and invasion may be apparent at surgery, with the tumor presenting in the middle thyroid and the jugular veins. Well, if we talk about the microscopy, the pattern is a well-formed follicles to solid to trabecular. Nuclei round to oval with a granular chromatin. The mitotic activity is present. Necrosis is absent, and the oncocytic variant HURTHLE cells major variant is there. So here we can see these are the follicles, the capsular, in case you see here we can see. So the follicular carcinoma is, there is a capsular invasion, there is a blood vessel invasion. What is the management? The FNAC, the fine needle aspiration biopsy, cannot differentiate between the benign and the malignant follicular tumors. One need to understand this. This is a very important point. That FNAC, if you will do, you can't differentiate between the benign and the malignant follicular tumor. So the pre-operative diagnosis of malignancy is difficult unless there is a distant metastasis. Large follicular tumors greater than 4 centimeter in old individual are basically taken as carcinoma. So any 4 centimeter large old individual having the tumor, we are basically suspecting it as a carcinoma. What is the treatment? Thyroid lobectomy. At least 80% are benign adenomas. One need to understand 80% are benign tumors. Total thyroidectomy in the older individuals greater than 4 centimeter. If the tumor size is greater than 4 centimeter, old individual, 50% chances that it is malignancy. So we will do the total thyroidectomy. Prophylactic nodal dissection is unnecessary. Now comes the post-operative management, the thyroid hormone replacement therapy, the suppression of the TSH release, the thyroglobulin measurements. Yeah, these need to be done. So we will give the thyroid hormone replacement therapy, suppression of the TSH release, and the thyroglobulin measurement. See, thyroglobulin is a dimeric protein. It produces and used entirely by the thyroid gland. So used to detect the residual or the recurrent carcinoma. Well, at 6 months interval, then annually, then when disease free. So we have to do it at different intervals. If see, the level should be below 2 nanogram per ml if we have done the total or the near total, and if should be less than 5 nanogram per ml in hypothyroid patients. We need to understand if the level is greater than 2 nanogram per ml, there is a chances of reoccurrence and a persistent thyroid tissue. So what is the post-operative management? Radioiodine therapy. Well, radioiodine therapy is less sensitive than the thyroglobulin in detecting the metastatic disease. 131 iodine detects and treats 50% of the metastatic differentiated thyroid tumors. So now we talk about the medullary carcinoma. These malignancies arise from the parafollicular C cells, and may secrete the calcitonin, carcinoembryonic antigen CEA, histaminidases, prostaglandins, and the serotonin. Female to male ratio is 1.5:1, account for 5% of all the thyroid cancers. Mean age of presentation is 50 to 60 years. Well, the types, these are the spontaneous unifocal 70% and the familial 30%. Spontaneous unifocal, which is 70%, are seen in elderly and no associated endocrinopathy is there. Whereas the familial 30% are inherited, autosomal dominant, and seen in the younger patients. Well, the clinical feature of the multiple endocrine neoplasia type 2. The three main variants are seen in the hereditary medullary thyroid cancers. These are the multiple endocrine neoplasia type 2A, type 2B, and the familial medullary thyroid cancer. Well, in type 2A, men, first we see the medullary thyroid cancer seen in 100%, pheochromocytoma 50%, hyperparathyroidism 10 to 20%, cutaneous lichen amyloidosis is rare, and the His+ disease. In familial medullary thyroid carcinoma, cancer, it is medullary thyroid cancer only 100%. Well, men 2B. So what is the difference between men 2 and 2B? See, in 2A and 2B, both medullary thyroid cancer and the pheochromocytoma both are seen. But in men 2A, we are having hyperparathyroidism and cutaneous lichen amyloidosis and His+ disease. Whereas the 2B, we are having the marfanoid habitus, mucosal neuromas, and the intestinal ganglioneuromatosis. So this is the difference. When we talk about the clinical features, non-tender thyroid mass is the most common manifestation. As it spreads to the regional lymph nodes, it may also present as a cervical lymphadenopathy in approximately 40 to 50% of the patients. May develop the flushing and diarrhea and Cushing syndrome, ectopic ACTH. Pheochromocytoma will occur in up to 55% of the men 2 patients. We know that a pheochromocytoma is present in both 2A and 2B. Diagnosis: the thyroid or the lymph node mass FNSC, along with the immunohistochemistry and the measurement of the serum calcitonin, leads to a confirmatory diagnosis in most cases. The patient should be screened for the red point mutation, coexisting pheochromocytoma, 24-hour urinary levels of the VMA, that is a vanillyl mandelic acid. What is it? Is basically the product of the metabolites of the epinephrine and the epinephrine and the non-epinephrine. Well, we know that epinephrine and the non-epinephrine belong to a group of similar hormones called the catecholamines. So this test measures the amount of VMA in 24 hours, which is passed through the urine. And then third is the hyperparathyroidism. Serum calcium is measured in 2A, because we know that hyperparathyroidism is present in 2A. Now the pathology, the macroscopic, solitary and unilateral. On cut section, it may present as a grey white to pink with a varied consistency. Grey white to pink with varied consistency. Histopathology. These lesions are composed of sheets of infiltrating neoplastic cells that are heterogeneous in shape and size. The cells are separated by a collagen amyloid and a dense irregular calcification. These cells are separated by collagen amyloid and dense irregular calcification. So what is the pathognomic of the medullary thyroid carcinoma? It is the amyloid deposition. MCQ. Now here you can see, this is a gross picture. A solid from unencapsulated circumscribed tan yellow to white. Microscopic, if we see that a solid proliferation of a round to polygonal cells of granular amphiphilic cytoplasm and medium-sized nucleus, and highly vascular stroma, hyalinized collagen, amyloid deposition. Here again we can see the tumor cells are strongly positive for the calcitonin. Immunohistochemistry. So what is the treatment of medullary carcinoma? Aim to remove all the disease and minimize the risk of the local regional relapse. For the MTC, medullary thyroid carcinoma, when the calcitonin is normal, if the disease is less than 5, if the size is less than 5 mm, the hemithyroidectomy is done. Well, the disease, the size is greater than 5 mm, the total thyroidectomy is done. So need to understand that less than 5, calcitonin normal, hemithyroidectomy. Greater than 5, calcitonin normal, total thyroidectomy. MTC less than 1 centimeter or 1 centimeter with normal basal calcitonin levels with a raised stimulated calcitonin. Total thyroidectomy with a central net dissection is done, removal of the level 6 nodes. Well, external beam radiation therapy is reported to reduce the local relapse in the patient with a limited nodal disease. Now, chemotherapy. Combination of regimens include the doxorubicin, streptozotocin, 5-fluorouracil and the dacarbazine have been studied for the disease stabilization. Well, the follow-up thyroid hormone replacement is required and monitored. All patients with a medullary thyroid carcinoma requires a lifelong review. So, for disease stages, best marker is the calcitonin and CEA. Well, the prophylactic surgery in the medullary thyroid cancer. The children and adolescents identified by the red screening are at a risk of developing the MTC. Therefore, in such cases, prophylactic total thyroidectomy is performed. So, before the age of 6 years. So, what is the age for the total thyroidectomy? Well, below the age of 6 years for men 2A and below the age of 1 year for men 2B. Now comes the anaplastic carcinoma, one of the most aggressive malignancies with a few patients surviving 6 months beyond the initial presentation. Presents less than 5% of all the thyroid cancers. Tumor affects patients 60 to 70 years old. So women are more commonly affected than men with a ratio of 3:2. Typically, patients have a long-standing neck mass that enlarges rapidly. This sudden change is often accompanied by the pain, dysphagia and dyspnea. More than 80% of those jugular lymph nodes involved at the time of the presentation. So now here you can see the gross pathology shows areas of necrosis and macroscopic invasion of the surrounding tissue, often with the lymph node involvement. Here is a fleshy and the white tan with a frequent necrosis and hemorrhage, entirely replacing the gland and extending into the surrounding skeletal muscles. Now, talk about the microscopy. The sheets of cells with a marked heterogeneity are present. Spindle, polygonal, joint, and the multinucleated cells are present with the occasional foci of the differentiated cells. Here we can see the first slide is an undifferentiated carcinoma of the spindle cell type. Well, in the second slide is an undifferentiated carcinoma of the joint cell type. So the management, the FNAC is diagnostic. The management of the anaplastic carcinoma is extremely difficult. Surgical debulking may be performed for the palliation. Initial therapy should ensure the airway protection with a tracheostomy and the nutritional support. All treatment forms are disappointing and the median survival is 2 to 6 months. One current treatment protocol involves the doxorubicin, hypofractionated radiation therapy and the potential surgical debulking. Although survival beyond 2 years is only 12%, this is the one and only regimen currently available for these patients. Now comes the thyroid lymphoma. Accounts for 8 to 10% of the thyroid cancers. Women greater than 70 years are usually affected. In 70 to 80%, it arises in the pre-existing chronic lymphocytic thyroiditis with subclinical or the overt hypothyroidism associated with the Hashimoto's thyroiditis, almost always non-Hodgkin's B-cell lymphoma. So usually present as a rapidly growing mass with the obstructive symptoms as dyspnea and dysphagia. Now comes the HURTHLE cell tumor, the type of a follicular cell carcinoma derived from the oxyphil cells of the thyroid. Function of these cells are not known. Cells are stuffed with a mitochondria and possess a TSH receptor and produces thyroglobulin. As compared to the follicular type, usually multifocal and bilateral and more likely to metastasize to lymph nodes. Where in the follicular, it is the most likely there is a hematogenous spread. But this, it is a multifocal and bilateral and most likely to metastasize to the lymph nodes, 25%. Now the thyroid metastasis. Usually layer common primary sites are the skin. 39% melanoma, the breast is 21%, renal cell carcinoma is 10%. Usually presents as a painless lump with the signs symptoms of primary. FNAC is diagnostic. Now let us talk about a type of thyroidectomy. Well, there are the 5 types. These are total lobectomy, the thyroid hysterectomy, the subtotal thyroidectomy, the total thyroidectomy, and the near total thyroidectomy, which is also called a Dunhill's operation. So let us understand this. The first is a total lobectomy. It is a removal of the single lobe of the thyroid. Then comes your thyroid hysterectomy. It is the excision of only the isthmus. So reserved for thyroid nodules of less than 4 cm size in the isthmus. So there we will do the thyroid hysterectomy. Yeah. Then comes subtotal thyroidectomy, near total thyroidectomy, and the total thyroidectomy. So what is the difference? Well, in a subtotal is a bilateral excision of more than half of the thyroid gland on each side together with the isthmus. So more than half of the thyroid gland is removed bilaterally along with the isthmus. In total, there is the excision of the entire gland. But what is then difference? The near total, only 10% of the gland is left. Excision of 90% of the gland is done, and that 10% which is left, the remnant is left at the level of the Berry's ligament. So that is Dunhill's near total thyroidectomy. So here we can see in this diagram very beautifully. So this is the thyroid lobectomy. Number A is the thyroid lobectomy. Only one thyroid lobe is removed. Next, B is near total thyroidectomy. So what is near total thyroidectomy? 90% removed. The thyroid gland 90% is removed along with the isthmus, and that 10% which is left around the Berry's ligament. Yeah. Then third is the C is a subtotal thyroidectomy. So bilaterally more than half of the thyroid gland is removed along with the isthmus. So bilaterally more than half of the thyroid gland is removed. This is the hysterectomy. So only the isthmus is removed. Only the isthmus is removed here. And this is the total thyroidectomy. The complete thyroid gland is removed. So steps of the surgery. First, we give the coccus incision is given. The transverse incision is placed halfway between the cricoid cartilage and the sternal notch. Tissue division through the subcutaneous fat and platysma. Superior and inferior flaps are raised in the subplatysmal plane. Then the investing fascia is opened in the midline from the thyroid gland to the sternal notch. Then the thyroid isthmus can be identified just after the opening of the fascia. Then the division of the strap muscles is done. The sternohyoid is to be dissected free from the sternothyroid. The latter lies deep to the sternohyoid muscle. The following by the division of the vascular pedicles starting from the superior pole of the gland. Here the superior thyroid artery is dissected. We should stay close to the gland as the injury to the external branches of the superior laryngeal nerve may occur. This is followed by the mobilization of the lateral aspect of the gland, followed by the dissection of the inferior pole of the gland. Here the caution should be taken to avoid the injury to the recurrent laryngeal nerve. So here we can see different approaches to identify the recurrent laryngeal nerve, the lateral, the superior and the inferior approach. So the lateral approach is a Bayes triangle. So here we can see this triangle here. So what is there in this triangle? So here is this superiorly, laterally we can see this is the common carotid. So laterally we are saying there is a common carotid. Yeah, this is laterally is the common carotid. This is a common carotid. Medially is the trachea. This is the trachea. And superiorly we can see the inferior thyroid artery. So inferior thyroid artery. So this completely makes a triangle. This makes triangle. So this is called the Bayes triangle. And superior approach is at the level of the cricothyroid junction at its entry into the larynx. And one is the inferior approach. So Barry's ligament is of the anatomical importance in identification of the recurrent laryngeal nerve. How? In the low Barry's, the nerve is close proximity to the gland, and the high Barry's nerve is laterally placed. So this need to be understood. Both the left and the right nerve follow closely with the course of the inferior thyroid artery. So identification of the parathyroid glands are to be done. Removing of the thyroid gland and closure is done in layers with a drain placed. Now the post-operative care in the patient. Position of the patient, elevation of the head by 45 degrees. A steroid therapy is given, IV steroids in the first 24 hours. Basically what happens is it enhances the analgesic and as an anti-emetic agent and reduces the chances of the recurrent laryngeal nerve neuropraxia. Proper prophylactic antibiotic is to be given. Calcium management, post-operative calcium levels are to be checked in case of the parathyroid gland removal. Well, if the level is less than 1.75 millimoles per liter, the patient has muscle spasm, cramps, tetany, paresthesia, IV calcium gluconate is to be given. Well, if it's less than 2 millimole per liter calcium, oral calcium supplements is to be given. Drain fluid monitoring done every 8 hourly. If the volume is less than 20 milliliter at 24 or less than 10 ml in the 8 hours, drain can be removed. So if the volume of the drain which has to be monitored every 8 hourly, it's less than 10 ml, then the drain can be removed. And 20 ml in 24 hours, then also it can be, the post-operative vocal cord assessment should be done for recurrent laryngeal nerve. Thank you.